Hi everyone, welcome back to the Bristol Poverty Institute Peter Townsend Memorial Conference, where we're focusing on poverty and the Sustainable Development Goals from the local to the global. So I'm the chair of this session this afternoon. My name's Maya Coley-Lynch. I'm a paediatric registrar, currently working in Gloucester. I'm also a researcher here at the Centre for Academic Child Health at Bristol University, where I'm particularly interested in global child health, child development and developmental disabilities. So I'm particularly pleased to be chairing this session this afternoon. So we're continuing with our child health and development session this afternoon. And this talk we have this afternoon is on early child development in disadvantaged environments, developing appropriate interventions, which will focus on issues really that we've touched upon earlier in the afternoon on child nutrition and poverty, and on the importance of play and responsive caregiving in early child development. I think earlier we were focusing more in the local context in the UK, and now we'll get a more global context and specifically an East African perspective. And my co-chair this afternoon is Dr. Matthew Ellis, who was the chair of the previous session. He is a senior lecturer in global child health here at Bristol University, and he's had a distinguished career in clinical community paediatrics and in global child health, both in research and teaching. So I just covered a few housekeeping rules before I go on to introduce our speaker. So the session is recorded and will be posted both on YouTube and on the BPI website. So by attending, you're consenting to taking part in the recording. We don't have a chat function enabled, but at the bottom of your screen, you should see a Q&A button. So if you have any questions throughout the presentation, just pop your question by clicking on the button there, and I'll pose your questions to Dr. Nampidja after the presentation. And if you could please keep your name visible when you submit your questions, so we know who the questions are coming from rather than just a guest or anonymous, that would be great. And as always, please be respectful, and anyone making derogatory or offensive comments will be removed. I'm sure you won't do that. So that just leaves me to introduce our speaker, who's Dr. Margaret Nampidja of the African Population and Health Research Centre based in Kenya. So Dr. Nampidja is a medical doctor. She gains a medical degree from Makerere University in Kampala in Uganda, and went on to study for and achieve a PhD in developmental psychology from Lancaster University here in the UK. Dr. Nampidja is currently a fellow with both the Wellcome Trust Makerere UVRI Infection and Immunity Programme and also the African Research Leadership Excellence Programme. She's got a wealth of experience working on studies focusing on social and biological impacts on early child development across East Africa, including on an early intervention programme for children at high risk of developmental disability, which I was lucky enough to work with Dr. Nampidja on. And Dr. Nampidja will be sharing with us this afternoon her experiences from her work across East Africa. So I'll hand over to you, Dr. Nampidja. I think Sarah is going to share your slides, is that right?
Thank you very much, Maya, for that brilliant introduction. I'm very humbled. Yes. Good afternoon, good morning, good evening, everyone, wherever you are, depending on the time in your location. I won't introduce myself again, but the topic that we are looking at right now that I'm going to present to us is early childhood development in disadvantaged environments, developing appropriate interventions. So when we talk about disadvantaged environments, in this case, we are focusing on poverty or impoverished settings. Next slide. Yeah, this is the outline of my presentation. It's going to be a quick talk, but we'll start globally with the relationship between ECD and poverty. What do we know globally? And then we'll go down to locally here in East Africa. What have we found? What have been our experiences? Then we'll go down to where are the gaps research and policy practice gaps, and what do we suggest as recommendations? Next. Yeah, like I said, globally, we know that early childhood development, or ECD, if you like, is critical for human capital and economic development of countries and the society at large. We depend a lot. I mean, our current and future generations depend on children developing fully, optimally, and developing to their fullness in terms of physical as well as mental development to be useful or productive adults, and therefore to support the economies and development of our society. But we also know that over 250 million children worldwide, especially in the low and middle income countries under the age of 5, are at risk of not achieving their developmental potential, with the biggest burden or biggest proportion of the burden in sub-Saharan Africa. This is approximately 67% of the burden of the risk is in sub-Saharan Africa. Poverty is at the center or the core of suboptimal childhood development, particularly in the low and middle income countries. Because of poverty or lack of resources, family and society poverty, children are not able to access the nurturing care that is necessary for their development. When I talk about nurturing care, I mean good health, nutrition, play, early learning environment, responsive care from their parents, protection and security. So poverty undermines the parents' ability or capability to provide these various aspects of the nurturing care that are needed for the kids to grow well. Next slide. Next, please. Yes, I won't dwell so much on this slide, but it summarizes the cycle of poverty, focusing on ECD, or the link between poverty and ECD and how this becomes a vicious cycle. So, sorry, I can't do the pointer, someone could do it for me. Kids growing up in family poverty, or kids born and raised in poverty, are, like you said, at risk of not accessing the good health, the good balanced diet, the play materials, the stimulation because the parents are stressed, and etc., which are needed for their development. And therefore, their mental functions or intellectual abilities will be compromised. They will not fully develop physically and mentally. This means that these are the kids that will not perform well at school. They'll not be able to achieve their education achievements. They might fall out of school because of low scores and stuff. And that means also that when they get into employment, they are the ones who are going to take on low-paid jobs or unskilled jobs that pay meagerly, and therefore this means that they are bound to be poor themselves. And when they get families, then they will raise their own children in poverty. So then the kids that they give birth to will also be raised in poverty, and the cycle is going to continue. So causing what we call intergenerational transmission of poverty, IGT. But we know that it's not all lost. We know that interventions that aim to optimize ECD outcomes can break the vicious cycle of poverty, as we'll see. Next slide. Next, please. Yeah, like I said, locally, what have we done? What evidence have we found, and what have been our experiences? We have, with colleagues and with different teams, run different cohorts and have conducted many observational studies as well as interventional studies in East Africa, particularly Uganda and Kenya. And a lot of our studies have been in what you'd call disadvantaged or low resource settings, including very rural areas, very impoverished settings, the hard to reach island or fishing communities, the slums of Nairobi. So I'm just going to share a few of the studies that we have conducted and what stood out for us in terms of evidence and as well as experiences. First, one of our early studies looked at maternal depression prevalence and correlates of maternal depression in Uganda. maternal postnatal depression. And we found that much as there was a relatively low rates of actual depression or clinical depression, we found about 20 or 25% of pregnant or postnatal moms having depressive symptomatology, meaning that these were at risk for developing full-blown depression. And we know the negative effects of maternal depression on the newborn. But we also found, importantly, that the risk for maternal depressive symptomatology was very strongly associated with low socioeconomic status. So that's one area where poverty really is playing a central role. We have also looked at newborns, where we found high rates of birth asphyxia, and this was still associated with low income, low socioeconomic status. And we know that severe birth asphyxia is associated with irreversible brain damage, and the developmental consequences can be very grave. Yeah, we have also looked at infectious diseases that are related to poverty. We know that worms are one of the neglected tropical diseases, but also called diseases of poverty. So we have examined the effects of helminth infections during pregnancy and found a moderate high risk of about 40% of pregnant women in Uganda in the cohort that we examined had soil transmitted worms, or hookworm in that case, if you wanted. And when we examined infant outcomes, we looked at the 5 domains of infant development and found that maternal worm infections during pregnancy were associated with negative outcomes in terms of language development and executive function as early as 15 months when you assess these kids. So we have also looked at poverty and how it affects health in general for children, and found that kids born or children born and raised in low socioeconomic status families are more likely to fall sick, to have frequent illness episodes, and hospitalization are the ones that are more likely to have severe malaria. And of course, we know the effects of severe malaria and repeated illnesses on the cognitive system. And next. Yes, we've talked about worms in the pregnant women, but we also looked at a cohort of children born to these moms, followed them up. You know, the oldest are now about 15, 16 years. We have been following them up, and we also investigated the prevalence and effects of worms on their development. We found that, again, worms or worm infections were related to low socioeconomic status. So we looked at the urban population, the urban sample, and rural population. We found that kids that were living in the very rural, for example, the islands of Lake Victoria, had a very worm prevalence and intensity up to 67% as compared to about 20% in those that were living in the urban. And when you compare it to economic status, the rural kids are really living in extreme poverty. So there was a close association between being infected with heavy worm infections and poverty. And then we found, though not very significant, some associations between worm infection, childhood worm infections, and child development, growth and development, even though when we treated, we were able to see a very significant effect of treating in terms of clearing worms, but we did not improve, didn't translate into positive cognitive benefits. We've also looked at growth, of course, as it were, and we have found high rates of stunting. And this was also strongly associated with poverty or low socioeconomic status, as well as micronutrient deficiencies, particularly high iron deficiency, which was about 30%. This is the paper is still in progress. We have also looked at the home environment, because As much as we have these biological exposures like health and nutrition, the environment or stimulation or caregiving are very critical for the development, especially in the first 1,000 days or the first early years of the child. So what we have found from a Ugandan cohort was parents are unable to provide what you call optimum nurturing care within the home environment. They can't afford to give toys or to buy toys for their kids. And those in the islands where they were living in shacks and extreme poverty, there was hardly anything in the home environment for the child to really to draw from it and develop all their senses or their different aspects of their development, even though we know that the home environment is protective and protect or buffer effects of other adverse factors. There's not enough stimulation within the impoverished settings. And in the Kenyan sample, we found that there is lack or there's poor ECD and childcare knowledge, attitude, and practices among caregivers in the slum settings of Nairobi. We did a qualitative and quantitative study where we actually found some of the parents thinking that kids have to grow anyway. You don't have to do anything. I mean, if you feed the child, they should be able to develop. So to them, development is something spontaneous, like you grow the beans and they should grow. And, you know, they didn't really have the idea that you've got to do something to enhance the child's development by providing stimulation, by speaking, being responsive, allowing the child to play and stuff like that. So that was in the slum setting, but we think that this is also related a lot to living in poverty. And we also noticed that behind or beneath, in the background of poverty, there were other very many factors that act in the background of poverty to aggravate the effects of poverty on ECD. We have all these cultures, the beliefs, the attitudes that are traditional, that act in the background of poverty to come out as negative practices of child giving, but these don't come out well. So that's an area that we'll be looking at. Yeah, we also found, in addition to cultural practices, gendered norms of caregiving where moms struggle alone and then the guys do not care. So that also creates a disadvantage, the kids that are in the first place growing in poverty and then being neglected by the second parent. So then our work has extended from the home environment, I mean, from care within the families to examine the quality of care within childcare centers or daycare centers, if you like. And what we found, this is in a study that we have done or currently doing in Nairobi in the slums, where we have mapped and profiled and also assessed the quality of daycare centers within the slums of Nairobi, and found that a lot of them are pathetic, sorry, the word, but they fall much below the desired standard. They're small, crowded rooms with a very high ratio of caregiver to the children. There's minimal number of tools, play materials. So the quality of childcare in center-based care is also not good in the slums, again, because of lack of resources. Next slide. Yes. So in terms of intervention, our intervention have been driven a lot by what we have found in observational studies, and this has been, of course, driven by the issues that we have found in the community. So we've had deworming interventions for both moms and for children in these settings where we have worked. So far, we have found not very strong benefits of deworming in terms of improving or correcting childhood development, even though we see that when we treat worms over and again, the worm burden reduces, but we do not see that translate into improvements in the cognitive or growth and development. especially in the high transmission settings, in the islands where the reinfection rate is also high. We have conducted, or we have implemented interventions, early interventions for neonates that suffered birth asphyxia. And what we found was that much as the intervention was feasible and very acceptable to the caregivers, we did not see it improve the quality of life of these kids or even the ECD outcomes. But we think that much as it was an early intervention, it was started as early as 6 months of age, probably we were dealing with very severe forms of disability, which were, if I can say, irreversible. There was irreversible brain damage, so this was an important factor. We have utilized modern technology, we utilize digital technology to see if we can bypass some of the hurdles that are challenging ECD within these impoverished settings. For example, we have just completed a study where we used mobile phone tracking and monitoring of developmental milestones of children, and also at the same time sending stimulation messages to the caregivers in real time. And this has proven feasible, not only feasible and acceptable, but it has also had real positive benefits for ECD outcomes in these settings. And finally, just another example is our work that we have done within the childcare centers within Nairobi. I've just talked about the very appalling situation in the child centers because of poverty, and we are working on a project to improve the quality of center-based care within the slum settings by working together with the center providers, the community health volunteers, and other stakeholders in the space of center-based care to see if we can improve the quality care. But so far, we think this is going to be very, very impactful, and it has been so far very received very well. Next slide. Next, please. Yeah, so what have we learned apart from the evidence? In addition to the evidence that we've captured from the interventions and the observational studies, we have realized that interventions should be given early. When given early, they have a potential to make a difference in terms of the outcomes. And also, if they are low cost, that's also an advantage. For example, the early intervention program, even though it didn't show significant quantitative effects, it was low cost and therefore was easy to administer. And also community of practice. When you have an intervention that involves the community, you co-design the intervention in the community, you involve them, it's more likely to win buy-in, and also for its sustainability, it's more likely to thrive through the challenges over time. And of course, that also speaks to participatory approach. It includes the various stakeholders, and also in its planning and delivery, it's likely to fare better than one which you just live and take it out to the community. And that's another approach that we think is very useful is leveraging on existing structures. For for a lot of our works, we have utilized the CHP system within the local communities, and these are very key gatekeepers in the communities. They do the basic health care support within their communities. People believe in them a lot. They know all about the households and who resides where and where to find what, and they're very eager people when it comes to programs. So this was also a strong point that we found working with CHPs was very, very useful. Also, what we found is contextualizing whatever you're taking out to the local community. You need to understand their cultures, you need to understand their values, their priorities, and you need to understand the key people within the community, and therefore kind of design your study, your implementation your program, your intervention accordingly. This has worked very well. And this is our experience with mostly studies in the Nairobi slums. I've talked about digital technology. It has the advantage of bypassing some of the challenges that can be faced with other models that don't use digital technology. Also, what we found is there's still a lot of room for male involvement, but where we have worked with fathers, such interventions have fared very well. And also, I talked about working with all stakeholders, including decision makers, right from the beginning. This promotes buy-in, but also it also promotes integration, but also translation of the evidence into policy and practice. Because at the end of the day, we do the research, but the communities have to take it on for going forward. Next slide. Yeah, so I've talked about some of the challenges, but now to highlight more on this, throughout our work in some of the studies that we've done, we have been faced with finding the right or lack of locally developed validated ECD measurement tools. A lot of what we have been using are adaptations of tools that were initially developed in the Western setting, where the culture, the socioeconomic status, and other contextual factors would make them not very fit for our setting. But we try as much as possible to translate as well as to adapt them to our setting. But you think that if we had locally validated tools here for our setting, that would be the most accurate, situation. We also experience high rates of attrition for participants from our studies in specific settings. For example, in the island or fishing communities where populations are always on the move. That really is a very important challenge for us. We also in East Africa, like you read from my bio, we don't have many ECD researchers, and those that are there are still working in silos. There is limited coordination or collaboration of research within ECD. People work in their teams and rarely meet except maybe at conferences, but this does not really promote the evidence to be visible and to be taken up by policy and practice. So that's also another challenge that we are facing, but we're doing, we are putting in a lot of effort to connect with other researchers in the region. And we're also seeing because of the poverty that is within a lot of the populations that we are working with, when we first connect with communities about a program, they have high expectations, especially monetary gains. And when you don't seem like you're going to give them money, they kind of pull back. And there's also slow integration into government systems of the evidence, again, because of limited resources. If they committed to some policy change, that would mean they would have to fund it. So, and already know that these are systems that are already burdened with very, very tight budgets. And that also speaks to the slow uptake by policy and the constrained health systems. And to this, I would like to say that, for example, in the slum settings of Nairobi, as well as the island settings of Uganda, there is lack of access. There is inequitable provision of services or access to services by these hard to reach communities or very impoverished settings. So you see that these are the communities that need maternal and child health or ECD services the most, but then they don't access them. So that's also a challenge to ECD related to poverty. And yeah, those are some of the challenges. And then we also think there are some opportunities that can be utilized to address some of the challenges or to make ECD outcomes, to optimize ECD in these settings. We have seen in most of the low-income settings that the communities there are expectant when they see a program coming. They really expect, they have so much hope in it. So they're usually very receptive. They are very welcoming and they're very willing, happy to participate. Despite the monetary gain they usually expect out of it. And also within the communities, we have social networks, we have community gatekeepers, we have the local structures that are within the community that you can ride on to be able to support whatever intervention that you want to be delivered, as long as you contextualize it to what they understand or to what they can support and utilize the existing systems. This can help the program to be successful. Next slide. Yeah, and finally, we had some recommendations for the challenges as well as the gaps here. We think that there is need for more research in the role of background factors or contextual factors beneath poverty. So we can look at poverty, but we need to look beyond it to see what is there, what is aggravating or what is amplifying the effects of poverty on ECD by studying the different contexts and also see what we can do about it. But a lot of it is about sensitization and education, especially in the low-income settings. And also what we recommend is, again, to investigate childhood resilience. We see that even within the poorest communities, the most disadvantaged communities, we see some good proportion of the kids, of the children being able to thrive. They can go to university and they can become very useful, productive adults. So what is it that they have or they are exposed to that the other kids who are not able to thrive do not have? What can we use then to help their counterparts out? So this is an area that we recommend for more research, and as well as the role of the fathers. I've already talked about it. And developing or locally validating measures for children in our settings, and also need for collaboration or coordination between ECD researchers, put together our evidence and put our efforts together to improve ECD in our settings. More involvement of decision makers at all levels of our projects or our programs. And in terms of policy, there's need for more financial commitments or governments to ECD and childcare. But we have also found that a lot of the problem with ECD and the fact that it receives minimal budget is because it is embedded in ECDE. It is the budgets, the understanding, the interpretations, the policies are made for ECDE, which is for older children, and therefore the 0 to 3 years kind of disappears or drowns in the the older children. So the young children are not catered for in most of the policies of ECD. And also the strengthening of public-private partnership, because there is a lot of work being supported by private companies and NGOs that the government is not involved in, and yet if they were supported, I think this would be very beneficial in terms of ECD outcomes. And finally, we know that women are the primary caregivers and the ones that fend for most of the kids, especially in the African setting, but we see that a lot of women are still struggling financially. So some of our work currently is looking at empowering women economically to see that they are able to earn enough and therefore support their families, especially their young ones, to be able to access the nurturing care that they need for optimum development. Next slide. So with that, I thank you all for listening, and I'm happy to respond to any questions. Thank you.
Thanks very much, Maggie. That was great. It's really interesting and wide-ranging walkthrough of your work across Uganda and Kenya, and I'm sure lots of it will be making a lasting impact on all the communities that were involved in those studies. I think we've got one question coming through in the Q&A. Just while I wait for others to come through, I'll take advantage of my role as chair and ask the first one. So I agree that involving fathers or male caregivers is really key. And I think we know from high income studies, including data from the ALSPAC cohort based here in Bristol, that involvement of fathers has a positive impact on child development and sort of behavioural outcomes. I think particularly in East Africa, where male figures in the household still hold quite a lot of power in the household, it's really important to get them sort of on board with childcare and improving early child development. But it's proving difficult in my experience. Do you have any examples of positive examples of engaging fathers in childcare and early child development?
Maya, is that for me?
Yes, yeah.
Could you repeat? Do I have any examples of where we involved fathers, you mean?
Yeah, managed to involve fathers.
Yes, we have, I've talked about the mobile phone technology platform where we used, we set up a platform where we sent monthly, questions on the 5 domains of development to each of the caregivers, asking them about the child, whether they were able, whether they had achieved this particular milestone. For example, maybe a 10-month-old would be asked, the parents would be sent a message asking, is the child standing on things? Are they attempting to walk? That's in the gross motor domain. Are they picking up stuff? Are they recognizing colors? Or do they have a social smile? Or are they saying mama, tata? So that would be sent every month, and we encourage the mothers. Of course, these were the primary caregivers and primary participants. We encourage the women to invite their husbands or the fathers to be around and to respond to the messages. So the messages were sent, but it was not just a matter of saying yes or no. The mom had to check, actually observe the child if they haven't seen already, and also respond. So in the cases where women engaged their husbands, this worked well. And we saw that these families or these participants were up to date in terms of responding, and also in terms of doing the stimulation activities that were sent. I mean, those questions were followed up with a stimulation advice to the parents. So where we saw a couple engaging in these observations as well as putting the advice in practice, it worked very well. So that's one of the examples. Also, in one of the studies in Uganda, the early intervention program, as much as it didn't have very significant quantitative effects, we saw a few couples coming along with their wives to bring the babies to escort the moms, the intervention sessions to the group sessions. We saw that improved qualitatively. We had the testimonies where this mom was happier than those who had been abandoned by the husband. So male involvement is very important. They not only support financially, but they also, the moral support has a direct or indirect effect on the ECD outcomes. Yes.
Great, thank you. I have a few questions now from Professor Eamons. So the first one is the lack of effect of deworming interventions on early child development because the Helminth load is essentially a marker of impoverished physical environment, which impacts on parent-child interaction? What are your thoughts on that?
Yeah, as much as worm infections can be used as an indicator of poverty, of course, worms or helminths have been labeled as one of the poverty-associated or poverty-related diseases. In our studies, and also in many other earlier studies, we have not found strong evidence or strong or significant effects of worms or their treatment. It might be that that worms may affect growth in terms of nutrition, but do not really have strong effects. And what we see, for example, in our cohorts where we examined worms, but of course, alongside we've looked at nutrition, we've looked at illnesses, we looked at the home environment, we've looked at malaria inclusive. So we found that other factors, especially the home environment and infections and nutrition, were more significant, were more impactful in terms of predicting or determining developmental outcomes compared to worm infection. So the discussion discussion of worms and cognition is still not conclusive, but it's more likely that worms do not actually get to the brain, or if they do, then they do it through other factors, for example, malnutrition.
Okay, so more work needed to work out what's going on there. The second question from Professor Emond is, evidence from elsewhere in the world suggests that the best way to promote resilience in childhood is investing in good quality preschool care. Should this be a priority policy area for lobbying government?
I have to admit that, like I said, resilience is an area that we are interested in, but haven't actually got down to investigate in these settings. And we cannot generalize resilience across contexts. I haven't come across any literature localized in Nairobi or in East Africa that has examined resilience. A lot of the work comes from other contexts, especially in the West or other low-income settings. So I cannot speak to that, but it cannot be policy, because what they receive, I'm giving an example of a child raised in the slums of Kibera. The health systems or the health services in Kibera are those for people living in Kibera, and unless this particular family takes their kids outside of the slum region to access better services elsewhere, maybe that could be the reason. But if we are looking at resilience at an individual level, then we've got to look at the individual and comparing them, or also comparing them with the other one that is not thriving well. So it may not be a shared environment. It could be something specific to the household or to the parents. I don't want to think it's genetic, because in the same family where you can find a resilient child, you may find others failing to thrive. So this is a topic I think that we need to investigate as soon as possible. I don't want to commit myself to any conclusions yet.
And do they, does the government in Kenya, are they listening to researchers? Are they prioritizing early child development and early childcare centres or facilities, or is there some way to go yet?
Yeah, to some extent, yes, but I think generally speaking, there's a lot to be desired. And like I said, their focus is on early childhood education. So that leaves out the very critical age group, and including, of course, childcare centers for 0 to 3 years. So I think that there are those gaps in access or provision of services for especially the youngest 0 to 3 years. So I think it's upon the researchers. I think one of their problems is lack of evidence, lack of data. So we as researchers in the space of ECD need to work very closely. We need to be the ones to look for the policy makers, because what I know is policy or decision makers do not look for researchers. So I think And that's the practice at APHRC. We have a very strong policy engagement department. So through that, we're able to be able to advocate or to promote our findings, our evidence, and sell them to the policymakers. But we know, of course, that that cannot be 100% guaranteed, because these are ministries that are still constrained in terms of budgets. But I mean, it also helps to push it.
Yeah, absolutely. Got a message from my co-chair, Dr. Matthew Ellis. He asks, this is relating again to preschool childcare centres. Are many parents using them? And with investment in training and resources, do you think they're part of the solution? And are UNICEF actively supporting this in Kenya?
I hope I've understood your question. Are many parents using preschool or kindergarten or daycare centers in these settings? And is that useful for ECD outcomes? I'm trying to interpret your question. Is that what you meant? Or
yeah,
could
so
I access it in the text?
Sorry?
I was just trying to look for the question in the chat box. But yes, a lot. You'd be surprised that even in the most resource, what's the word? I don't want to use the word, but even in the most poor or the poorest context, the need for daycare is still there, because parents need to work. They are poor, but of course they also need their work, even though they earn little. Every day they wake up to go and look for money, and of course they engage in those unskilled jobs. They work in factories. They're the ones who do the cleaning jobs in the upper part of the city. So the moms are very busy, and of course they have families. So every day they need someone to take care of their kids. They cannot go with their babies to work. So the need for daycare is there. And what happens is someone is there to provide what they can afford. So that's why you see a lot of daycare centers. I think it's estimated that in Nairobi, there are about 30-something thousand daycare centers, informal daycare centers, informal as in really not reaching standards, because the demand is high. These slums are very, very highly populated, and a lot of the moms are working, and we don't have the extended family systems that we used to have. So there is a mamapreneur around the corner who is willing to do the job of keeping these babies as the moms go to, to look for work elsewhere. So there is a lot of use of daycare centers, and how that then contributes to ECD. It is a good thing for babies to be looked after. Otherwise, they'll be neglected. I mean, you'd find them along the sewage lines playing or just abandoned in the community, but at least someone keeps them. But what we have to do is to help improve the quality of care within these centers. And this is because what the caregivers, what the moms can afford to pay cannot support what would call good quality. So, and even the mamapreneur or the owner of this informal daycare earns very little from that business. So they cannot put in so much more than what they will be getting. So, I mean, we think there should be an external intervention, like maybe the government, to support informal daycare. Yes.
Yeah, and I suppose quality can be quite hard to measure in childcare, but even sort of basic measures of sort of staff to child ratios are important to look at. And from what I've seen, it's still many children to staff members, and perhaps sort of staff members untrained to in sort of childcare and early child development. Any more questions in there's no more questions in the Q&A, so I'll just ask one more. You mentioned that one of your studies had found a link between birth asphyxia and poverty. And were you able to look at sort of the reasons or the intermediary factors there, how poverty was resulting in children born with encephalopathy or birth asphyxia?
Yeah, this was a mixed methods design or mixed methods study where we had the qualitative work as well as the quantitative. Qualitative work showed that as we had conversations or interviews with the moms, we realized that the story really points a lot to lack of resources or poverty. The mom cannot afford to deliver in hospital, and sometimes simply because she has no transport to go to hospital, or maybe she fears that in hospital they are going to ask for money. They will ask her for gloves and cotton and all these utilities. Sometimes they ask even if it's a government hospital. So a lot of moms would first try to deliver from a TBA, traditional birth attendant, or a small clinic around the corner in the village or in the small town. And once things fail, then they refer themselves, or the TBA comes with them to the hospital for a cesarean section, an emergency cesarean section. And by then it's really late. The child is tired, as they say. So a lot, when you ask father, she can tell you that I didn't have money, my husband was not around, things rotate around poverty. And also like in the rural areas, moms living very far up country, the transport system there is very difficult. And again, because of money, so the mom will start feeling labor pains and she gets onto a border because she cannot afford special hire. I mean, that community poverty also contributes the fact that moms are not able to report to hospital in time, and therefore they get there when it's really late and the child has gone through birth asphyxia and irreversible brain damage.
Yeah, I suppose that's where the qualitative work really comes into its own, and start to dig down into the reasons, what the factors involved leading up to that birth asphyxia episode. So I don't think we've got any more questions, so we'll wrap it up there. So that just leaves me to say thank you very, very much to Dr. Nampija for joining us this afternoon and for that really insightful talk you've given us. And thank you to everybody who attended and participated. I hope you enjoy the rest of the conference. I think we've got a meet the team session from 5 till 6 o'clock. So we'll give you 7 minutes to have a little break before joining us back for that.
Thank you too. Thanks everyone for attending. Thanks.
Thank you, Margaret.
Thank you, Matt.